Okay. So when we talk about ethics, we talk about basic ethical principles. The first one, obviously, the one that will govern all of your ethical scenarios in most cases is autonomy. We have heard the term before, we know what it is. It is simply the most overriding principle of all of ethics. Whenever we talk about patient autonomy, it means that the patient has command over everything that is surrounded uh, to their medical treatment. So they will have the power to their medical decisions. They will have the power to confidentiality. So all of them, that is their autonomy. There is something. There are obviously some exceptions and some catchy things around this topic as well that we'll be covering as we go on. But one thing that you need to know for now is that the patient must be legally competent and they must have decision making capacity. Those two are different terms. When we talk about competency, it's a legal scenario. It is something that is only a legal governing thing. So you cannot determine whether somebody is competent or not. Only a legal body can do that, such as a court. But for capacity, which you will be tested on a lot, that is something that the physician judges, and we'll come to how the physician can judge that the patient has decision making capacity or not. But for now, you should know that autonomy needs that the patient has decision-making capacity. Otherwise, we cannot rule that in. The next thing is that whenever we talk about autonomy, we need to understand that the physician still has to convey medical information to the patient. It cannot be that the patient has got complete autonomy over everything without having any knowledge. So obviously, whenever you have got important medical decisions, you don't jump to autonomy in most cases. So you'll see these scenarios where a patient is, for example, I've described one scenario about a vaccine. So if a patient is denying vaccination, it does not mean that you just respect the autonomy straight away. You have to explore, you have to identify what are their reasons, you have to provide them the information, and then only autonomy comes. And this is all part of decision making capacity, as we'll come to know. But this is about autonomy superficially for now. The next core principle, obviously, beneficence. It is obviously the physician wants to act in the patient's best interest, and that is the primary goal. But only when it conflicts with autonomy that we actually take autonomy first. Otherwise, we are trying to go for beneficence in most cases. Non-maleficence is slightly different. Now, this is something that they can confuse you with. They could give you a scenario where the patient has the physician is trying to do no harm to the patient, but it's not really a direct benefit. So you need to understand and distinguish between the two, whether it's the case of non-maleficence or beneficence. The fourth one, justice, and the key scenario that you will come across in your USMLE exams is around emergency scenarios and triage systems, because there you have the principle of equity and not equality. What does that mean? Is basically means that everyone who deserves the most amount of care gets the most amount of care first. So you have to have an equitable distribution of your healthcare. It cannot be that everyone is receiving equal importance. Obviously, someone with a more life-threatening scenario in an emergency case may require more urgent attention and more resources allocated towards them. So this is why justice is an important principle. The fifth one, it's not something that you will read in ethical principles, but I like to include in ethical principles is the principle of empathy, because in every scenario that you will see in your question stems in USMD, you will have empathetic approach being the right answer. You will have two approaches that you will get at the end, and one of them will be more empathetic, and that will be somehow the right answer. This can get tricky for the initial parts, but once one gets familiar with all of those scenarios, they may find that they are able to identify empathy a lot easier. So always prioritize the patient. That means that when a patient is coming to you and they have people surrounding them, whether it be their parents, whether it be any other accompanying people, you need to focus on the patient. You need to keep your attention on the patient. You need to keep your goal oriented to the patient. So that would be in terms of communication to the patient. That would also be in terms of whether to have a medical decision, obviously. But always prioritize them, not your own values, not the people with them. Always listen and explore. So whenever you have got scenarios that are communication scenarios, you need to have open-ended questions. And open-ended questions will win against a closed-ended question or direct information any day in your USMLE exam. So you cannot just directly provide something without establishing what the patient wants or what the patient is presenting with, you have to start your doctor-patient relationship by an open-ended question. That is always the right answer. So whenever you have an open-ended question, think about that. And empathy does not mean false hope. It is a very common scenario that they test on. They will give you two options between a communication line, and they will tell you that in one of them, the physician is actually giving them the false hope that they're trying to be empathetic, but they're denying that fact, or denying or hiding that fact that needs to be known by the patient. So you have to be accurate. You have to still display empathy. You cannot give false hope. If a patient is in denial, you cannot just be happy that they're in denial with a very severe condition of them, and you need to redirect them to the right path while being empathetic. And one thing I always like to teach when it comes to empathy and its related questions in USMD question stems is that always imagine yourself in the patient's position. When you are stuck with the question, always imagine yourself in the patient's position and think of what option would you want to hear from the physician themselves. What would you like better? That is somehow always the right answer. So focus on that. Most of ethics scenarios will require you that you give time to each of its options. That is the key to cracking ethics, and that is something that works and something they should apply. Okay, so the next thing, uh, a key thing to know about is the EMTALA Act. It is the emergency like the emergency code of United States. So something that a physician needs to do is that they need to deal with all emergencies regardless of the insurance status. So they will give you some scenarios around this. What they will give you is that a patient is presenting to the emergency, or they're presenting with a complaint that looks like an emergent complaint. You need to stabilize that patient. Your EMTALA Act surrounds the stabilization phase, the emergency treatment of that patient. Beyond that, the care needs to be, it depends on the insurance status. So if the patient is not insured, or the patient does not have funds, the physician is not obliged to provide the medical care. But prior to that, any emergency stabilization, any emergency care is free of cost, and the physician has to provide it. So this is something that they test about. They can either test you by directly asking you what act is this, what kind of code is this. You will be asked about the EMTALA Act, and they could also test you that a physician is coming in, and you would be given this option that they need to be stabilized without any further insurance status, without any information about them. That needs to be discussed with them. So this is how they test it. Now, transfer of care is only possible to another physician while you are a facilitator. So you have to be a facilitator for transfer of care, and obviously transfer of care is an important element that can be done for various reasons, and a physician can do that. That is something that you should know. A physician has the ethical right to deny a certain care that is not consistent with their own cultural norms or religious beliefs. But what they have to do is that they have to transfer the care to another physician. If they are not doing that, then that's not the right approach. That's not the ethical win-win scenario for them. So what happens with such transfers is that another scenario could be that the physician is actually traveling somewhere, or the physician is sick or anything like that. But that is how it happens. Another scenario that it would happen is when a physician has got a family relative or a close friend coming to them for their care. So what they need to do there is that, as we will come to know later, that you cannot provide medical care to them unless it is an emergency, obviously. But generally, you cannot provide care to them. So what you can do is you can facilitate the transfer. Now, two things that autonomy, people with high precedence for autonomy can get confused with is that the physician is not obliged to provide medically futile treatment. There are two things. One is medically futile treatment, and the other one is a non-medical indication. For example, if something that is not medically indicated at all and the patient is asking for it, you will not respect the autonomy there. You have to tell them that it is not medically indicated, and I cannot do that. It can be going down to something as simple as an antibiotic prescription. Just because the patient wants an antibiotic prescription, we will not do that. Just because the patient wants a screening test and it's not indicated for them, you will not do that. So obviously, screening tests and Any kind of medical indication which not there, autonomy is not respected. Any kind of medically futile treatment, for example, the patient is already brain dead, and the family relatives are asking for some kind of intervention that may restore the patient, and obviously the patient cannot be restored, so a physician has the right to decline that treatment. So in two scenarios, medically futile treatment and medically non-indicated options, a physician is not obliged to provide care, and that is something that conflicts with autonomy and should be known. uh, Again, that's the same point. And finally, patients have a right to the copy of their medical records. They cannot have the original records. The original records belong to the hospital, and also the original records cannot be tampered with. Again, something that challenges patient autonomy. When you have got a patient who is trying to tell you that I do not want this included in my medical record, for example, it could be a very confidential thing. For example, it could be AIDS, it could be other sexually transmitted diseases, or it could be something that they are embarrassed about. In this is, for example, they do not want it to go in their medical record. You cannot do that. You have to have original medical records, and you have to deny that request for them. But you can provide a copy of their medical records, and the original will stay with you. And finally, patients have a right to leave against medical advice. Obviously, you do not have the capacity to hold them when they are wanting to leave. But obviously, one thing that we need to know is that you need to provide options for continued care. So this is also something that they test. A patient wants to leave you, a patient wants to go away. You need to have the empathetic approach of trying to provide that continued care, however it is possible, whether it is through telephonic communication, whether it's through a follow-up, anything like that. So that is something. Now, the most commonly tested scenario in ethics is that who can give informed consent or who has the power to a medical decision. They will give you a scenario and they will give you different medical decisions taken by, for example, the patient, for example, their close ones, the physician themselves, who has that power. So obviously, there needs to be a hierarchy followed for that. And that is something that we need to know. And it is possibly the most clear-cut, direct uh, scenario of ethics when you have got this, because when you have got medical decision making, nothing can go wrong if you follow this particular hierarchy. So the number one thing is the patient has got the topmost priority. Obviously, we talked about autonomy, we talked about how it works. So they need to have decision making capacity. We'll talk about that very soon. They need to be 18-year-olds or more, and or they could be a minor, but they are legally emancipated. We are discussing all of that. What is decision-making capacity? First of all, you need to understand it is assessed via the teach-back method. The teach-back method just means that you are providing information and hearing the information back. So that is something that you should know. You can be tested about this. The first thing is that the patient needs to understand the situation. How will you know that? Because obviously you will provide the information, they will communicate it back to you, know that they have understood the situation. They are communicating their choice. They will give you a rationale for that choice, what they want or what they do not want, and they will appreciate all the facts surrounding the scenario. But this is something of a gray area in decision making capacity and something that can confuse you. But what you should remember that the patient has a right to refuse information. Every patient has got a right to refuse medical information. That does not mean that they will be out of the decision making capacity just because of that. If someone is giving you a choice and someone is giving you a rationale, but they do not want to hear all the facts or hear the medical information that is necessary for them, it is still valid capacity. So something that does not deny, because obviously you cannot just because of a patient's concern, for example, they're too distressed about it, they do not want to hear, it makes them emotionally upset, it is a sad news, something like that. You cannot do that to just rule out decision making capacity. Next thing is, what is confusing to most students is that they think of it as a psychiatric assessment. It's not a psychiatric assessment. Even in psychiatric cases, even in cases where the patient is mentally challenged, it is not a psychiatric assessment. It remains the physician assessment. So you will never have this as the right answer that the physician is requiring a psychiatrist to come and evaluate for the capacity. You will be given that option in most sense, but that is not the right answer. If the physician themselves can understand these 4 points, that the patient is understanding the situation, they are communicating a choice, that means the physician can establish that they have decision making capacity. And that's all they need to do. Whenever you're thinking of a medical decision power, you need to see whether the patient has decision making capacity or not. It will be a long question stem sometimes, it will be a short question stem sometimes. Just see that the capacity is there or not and mark accordingly. And obviously, you cannot confuse it with competence. I've discussed that previously. Legal emancipation means that the minor, for minors, if you have got power of medical decision making autonomy, they need to be more than 13, and either of whether they are married, whether they are parents, whether they're in the army, or whether they're legally emancipated by the court for whatever reason. So that means that they will have the autonomy there. Okay, so one thing is that obviously with this situation so far, you know that the minors do not hold the autonomy to their decision making. The parents hold that. But how does that change? We'll come to that. Uh, First of all, we talk about decision making capacity, right? In emergency situations, when you're trying to act in the beneficence for the beneficence of the patient, you do not need that decision making capacity. There's a phenomena called implied consent. And implied consent means that you do not follow that protocol and you go for the best interest of the patient. This applies to adults, this applies to children. For children, uh, no other medical power can outdo that decision in emergency situation. For example, a parent who has normally the right to their medical decisions, to their children medical decisions, they cannot refuse medical treatment of their child if it is a life threatening treatment, if it's an emergent scenario, not other scenarios. We'll come to other scenarios in a while, but emergent scenarios, implied consent, children always get treated. But for adults, there is a line that I've written here that the hierarchical power can alter the medical decision once available. So you may find a patient who is for example, uh, intoxicated, incapacitated, but they require, for example, intubation, but they have a DNI order, and it's part of their either a documentation, a living will, or an attorney has documented that. You can just follow that hierarchical power. You cannot you cannot just go for beneficence, and you have to respect the patient's predetermined decision, because that is an adult taking a decision for themselves prior to such a scenario. And they're taking such a decision for such a scenario, obviously, because they will lose capacity and they want what is the best course according to them. So they will predetermine that. So for emergency considerations, you need to remember that for adults it's different, for minors it's slightly different, that there's no hierarchical power scenes here. So always go for beneficence for minors. And the classic scenario that they test on is something that you will see is about Jehovah's Witness, where they do not allow blood transfusions. But for children, you will have to give them blood transfusions, even if they belong to such a family, right? So next thing, exceptions to patient autonomy. Another exception comes in. We have patient who has serious risk of harm to themselves or to others. Themselves obviously meaning suicide, and others means obviously they have demonstrated that they're either in extreme psychiatric illness and giving you their intentions of harming others, or they're just giving you that plan. They just give you a whole plan, or they just give you that intent. That means that the autonomy cannot be respected. In that scenario, what you need to do is that if that is a legal scenario, if the patient is trying to kill someone, you just inform the legal authorities, such as the police, and you have to hold the patient then. You cannot just let them go from there. So you have to possibly involuntarily admit them if they are not going through a voluntary admission. We'll come to involuntary admission later as well. But for now, that you need to know that autonomy cannot be respected in such scenarios. Uh, Confidentiality is also not respected here, obviously, because you're leaking information the patient has told you, which normally should be between a patient and a physician, but you have to leak that because there's harm to others. Pregnant individuals have the right to take a medical decision, even if it poses a risk to unborn fetus. But abortion is still illegal. So what you would not get in your question attempts in the USMLE exams is you will not get a question on abortion and whether it's the right course of action or not. Secondly, but you can get scenarios obviously where the pregnant individual has to take a medical decision. They're taking a drug or they're taking something that is medically indicated towards them, and it poses risk to the fetus. They can still take it, right? Minors have right to confidentiality and decision making with sexual issues. We talked about legal emancipation, making minors giving them the decision making capacity in all scenarios. But normally, even without that emancipation, they have this confidentiality and decision making power with the sexual issues. What are that? There are the STIs, there are contraception, there are pregnancy, but not abortion. We have discussed that it's illegal in most cases. And finally, we have addiction care as well. Addiction care is something that people miss. They only remember the sexual issues, but addiction care is there as well. Finally, that means that not only the physician has to respect the confidentiality. That means also means that the physician will provide the medical treatment. No sort of communication can take place between the physician and the parents that the patient has gone through this particular scenario. That's supposed to be remaining confidential, unless obviously the patient wants it. If the patient wants something regarding any of their confidentiality, it's the patient's decision. They can do that. Finally, components of informed consent. Just like making capacity, something regarding informed consent that a physician takes for any kind of medical decision from patient in non-urgent scenarios, you need to know the components. And once you know the components, you can apply them to every question stem, and you can know whether the informed consent was taken or not. So benefits and risks of a medical intervention has to be provided. Alternatives to the medical intervention needs to be provided. And what would happen if the intervention is not done? So if the intervention is not done, you need to provide the adverse effects or whatever kind of things that will happen to the patient. And some of the terms that you should know about here, the capacity needs to be there. Whenever you're taking informed consent from a patient, they need to have capacity, they need to have voluntariness, they need to be disclosed of all the information, and they need to be free of coercion. You cannot have any kind of persuasion there. There is a form of counseling that is called directive counseling. You may have mild persuasion in that, but that is only done when there is only one medically reasonable option. So if a physician sees that there is not two options here and one is clearly harmful and one is just a medically reasonable option, you have to have some form of directive counseling there. You cannot just let it go and respect patient autonomy. And only someone with practical knowledge and responsibility for that procedure can take the consent. This is something that they test. If you are an intern, if you're a resident, you do not have that clinical or technical expertise regarding a procedure, but the superior is asking you to do that, you have to politely ask them to do themselves, because you cannot take the informed consent. It's ethically wrong. Only someone who can take it, has the expertise, they can actually go for that. So that is something. Now I've written here that informed refusal has same components. Most people are aware of the concept of informed consent, but informed refusal is something that is very useful in one particular situation. What it means that basically when the patient is refusing a treatment, that is also just exactly the same as consent. For example, they will hear the benefits and risks of medical interventions, will hear the alternatives to that. They will hear that the intervention is not done and they're refusing it. So that is, it's the meaning of it is simply the same. They're just not consenting to it, they're refusing to it out of the same components. But when does it apply? It actually applies when you have an emergent scenario. You see patients that are coming to you and they are just rejecting a medical treatment, but they did not display a full capacity, they did not display the full consent. So informed refusal has to be there for them to refuse that treatment in the emergent scenario. That is where it applies. For example, if you have a patient coming in crashed and he just says I'm in a lot of pain, or he just tells you to not do anything to him, and he's just verbally expressing that, he's not done an informed refusal. You cannot reject that medical treatment for him. You have to have a whole all of these 4 points. So in an emergent scenario, informed refusal concept is important. So you just don't just stop there and you actually go on with the medical treatment. That is something that does come up in this particular scenario that I have told you. So refusal, on the other hand, can happen. What is refusal? Refusal means that the patient does not require an emergent treatment. They have just refused a treatment that can be withheld because of lack of capacity. They were intoxicated or they were anything like that. They just refused something. But that treatment was not indicated at the very earliest. So what you can do is that you can accept that refusal. You will not just go on and just do that treatment even when it was not urgent, because the patient can have capacity later on and they can give you that consent. You just wait there. You accept that refusal and you wait. So informed refusal does not apply there. Informed refusal only applies when you have got emergent scenarios, right? Now, what do we have next? We have the second power. All of that was around the patient. We have the advance directives if they are present, wills, legal attorneys, oral advance directives. That is the second tier. The third tier is the family. Spouse comes first, and in spouse, you need to know it's a spouse. It is a legal partner only. It can be someone's fiance, it can be someone's girlfriend for a long time, but it does not apply to their medical decision making. So those two cannot make a medical decision. Only the legal partner can. Adult children, the next, parents next, and finally adult siblings. What something that you will see very common is ethics committee in a lot of options when you're doing question stems, and a clear cut indication of an ethics committee being the right answer is only one. When you have got no family consensus, you have got a conflict between two people, for example, two adult siblings that have a conflict with a medical decision, and there's no other surrogate decision maker available, for example, even if you're trying to contact them. Now, this is something important. The ethics committee cannot be directly involved without you trying for everything that is possible. For example, you need to try for contact when the surrogate decision maker could be present. For example, it could be a parent living long away. You can have a telephonic communication with them. This is obviously all non-urgent scenarios. In emergent scenarios, you don't really need that. Obviously, you will be going for the implied consent, just like we have discussed previously. Now, this is around this. What I need to tell you that is that there could come scenarios where you have got patients coming uh, in requiring some form of treatment, but they do not have capacity to give consent for themselves. So the next things comes on. They do not have their advanced directives, and finally, they do not have a family. But some neighbor is coming in, or some other form of individual is coming in, a friend or anything like that, and they're giving you some form of decision for the patient that they think is the best for the patient, and they think that the patient would have also wanted that. You cannot consider that decision. You have to try to contact their real team. And if that is not possible, then you take the case to ethics committee for a non-urgent scenario. So in a sense, those lines are actually waste lines when they are coming in question stems. When you have got an individual who does not hold any right to a medical decision, giving you with any kind of information, just ignore that. So outside of these groups, no person holds power to a medical decision, no matter how close, no matter if they're offering substitute. They can offer you substituted judgment. And when we talk about medical decision making, we need to respect substituted judgment, which means that the physician needs to know that outside the patients, anything that is giving me the medical decision needs to be having substituted judgment, which means that they should respect that the patient would have wanted this particular thing for themselves if they had the capacity. That's what substitute judgment is. So this is something the physicians they could give you in question stems as well. That the physician, what is the next step that the physician should do when you have got lack of medical decision? They should ask about substituted judgment. They should ask the family or the uh, whatever component of the family could be. Okay, what is the substituted judgment in that case? Okay, so whenever there's a disagreement between two surrogate decision makers, the first thing is to arrange a meeting to reach a consensus. Now, this is something that is slightly contrasting. And here I would like to touch upon the ethical way of doing things compared to the legal way of doing things. When you have got an ethical way, the legal way says that, for example, if there's a conflict between a spouse and let's say adult children, the spouse holds the higher power, right? But the ethical way is to just have a meeting between those family members, and it could happen that they may come to an agreement. Now, this is obviously in cases where you have got no urgency of medical treatment, but this is something that they test you about. They can give you two options. They will give you a medical decision of a spouse. They will give you medical decision of their children, and they will tell you that the option to go with, they will give you two options. The first option will be to involve them in a meeting. The second option will be just to follow the decision of the spouse. Legally, that's the right thing to do. You can do that, and eventually you will have to do that if the meeting does not reach a consensus. But ethically, the right approach should be to have a meeting. So this is something why family meetings is in there in the option. Sometimes you will see that, and question stems you need to know that when is family meeting the right answer actually. So this is the scenario when it's the right answer, when there is a conflict, and you need to do that. As a physician, I have told you this, they want substitute judgment is need to be explored. Finally, we have got some tricky ethical dilemmas surrounding these scenarios. So let's say the patient is intoxicated or has altered mental status. What is the answer around those scenarios? You will assess the capacity after treating the reversible causes, right? For example, if the patient is intoxicated, obviously you will just deal with the time. You will give them an antidote if necessary. You will treat them for any other kind of poisoning if necessary, and then you assess the capacity for any kind of non-urgent decision. For urgent decisions, I've told you this: informed refusal should be followed, right? Informed, if they can refuse it with that full information, like in an informed consent, then only you just reject that treatment. But if they're just giving you that verbal command that, okay, I do not want this, I do not want that, and they're obviously not in the right state of mind, do not follow that. Simple refusal is enough. If an intervention can be, for example, if a patient comes in to you with an abscess, it needs not to be drained immediately, right? And they tell you that they're intoxicated and they have an abscess, and they tell you that I do not want treatment for this. Then you don't just treat the abscess. You wait, you let the intoxication clear up. You have the patient come back to capacity, and then you assess the capacity and then you treat for that. Next thing, patient withdraws consent. They can anytime. Anytime the patient can withdraw the consent, they can be just have going to the operation room and then they can withdraw the consent. So that's their right. But what you need to understand as a physician, you need to ask the question why. You need to ask what happened. You need to ask what are the reasons that you come to this decision, because you need to reassess the capacity. It could be that the patient now lacks capacity. They initially had capacity and now they lack it. So you just need to reassess that. If they are demonstrating that they have full decision making capacity, you respect that decision. The next thing, child disagrees to a parent's medical decision. Now, we talk about how parents have the right to their children's medical treatment. So legally, the decision lies with parents. But an ethical scenario, again, is ethics versus legality. An ethical scenario would not mean that you just reject the child and you say that the parent's decision will be followed. The ethical scenario would mean that you involve them in a meeting again. This is called shared decision making. You ask the parents to involve their child with the in the shared decision making. So again, if the child is not consenting to it till the very end, and the parents are, you have to follow the parents. So this is how ethics can be tricky sometimes. Now, what if the parent disagrees to disclosing information to the child? Again, you have to respect that, because parents have the rights to medical decisions when it comes to children. But when it comes to disclosing information in particular, when the child cannot even know about their disease, that is something of a gray area, right? So what you need to do, what the only thing that they could ask you about for this particular scenario, they could ask you about forming a plan. And the plan means that eventually the child should know what their condition is. They should know the information. Even if they're not having the medical decision to what the right treatment for themselves is, they should have the information, because that obviously makes everything easier. So you have to respect the decision, but you have to form a plan in which the children eventually will know the information. Now, another scenario, child disagrees to research. Now, this is something different from medical treatment. Now, consent is something that the parents provide for medical treatments and for medical decisions, but assent is something that is given by children. And for research, assent is important as well. Assent means that the children needs to agree with that. And if a child does not agree to research, they can opt out of it. The parents cannot force themselves, because this is not something that could benefit the children. This is not something that lies in medical treatment zone. So obviously here the scenario is different. So those two scenarios with medical treatment and research, they differ in children. The next thing, patient disagree to an urgent or eventually life treatment. Now, this is different from those two extremes. One is an emergent extreme, one is a non-urgent extreme. But in between them is the urgency, or a condition that can eventually destroy the life of the child. It could be a cancer, it could be leukemias, or most common in children. It could be tetanus. If the child has got exposure to obviously the bacterium in certain kind of injury, then the tetanus vaccination and the toxoid, as indicated according to the guidelines, would be warranted for saving that child, because if that is not done, then they have potentially life-threatening conditions. Such scenarios are what we call as urgent scenarios, and here we need to take court orders. Court orders are the right answer to only one particular scenario in ethics, and this is this scenario. Urgent treatment for a child that is not life-threatening immediately, that's not emergent, but it can be life-threatening eventually. So you disrespect the parent's medical decision. You try to seek a court order for treating that child, because you know that the treatment is important. only one parent is agreeing to treatment of a child, the other is not, you can only take consent from one parent. So that is enough. So sometimes they will give you that one parent is agreeing, the other is not. Finally, psychiatric illness or dementia in a patient is not equivalent to capacity. They will give you very severely patients with very severe Alzheimer's, patients with very severe psychiatric illness. You do not care about any of that. Just go back to your basics. When you see such a question stem, the basics say that you see whether the patient has capacity or not. If they're displaying capacity, which means they're displaying their choice, they're giving the rationale, they're giving, uh, they're understanding all the information, you make a decision based on capacity. You cannot just decide that the patient cannot do that because of their illness or dementia. So always negate those elements when you see them in an ethics question. Then you think of capacity, capacity, and capacity when it comes to medical decisions. Finally, parents disagree to some medical treatment for a child. They can, they have the legal right. But again, we have explored it previously as well that we need to explore scenarios when autonomy is conflicting with beneficence. Whenever there's a conflict between autonomy and beneficence, at least explore that. At least try to provide the best care. At least try to provide the best information. In the end, autonomy succeeds. The parents have the right. In the end, it cannot override your decision. It must override your decision, but always explore, always attempt to understand why. So these were some scenarios regarding to what we have done so far. The next concept is of confidentiality and disclosure. Patients have the right to all the medical information related to themselves, and the doctors must maintain confidentiality between themselves unless there's harm involved. So we have discussed that was an exception. Harm could not be involved in confidentiality. You need to leak that information out, whether it be to the police, whether it be to the third party that could be there at an immediate threat. Exception is obviously, according to the HIPAA protocol, we have something called as the minimal required information. Now, what does that mean? That means that partial details about medical stability, at least, or the clear cut health status of an individual can be revealed. It can be revealed to a contact in an emergency setting. Somebody might come and they might tell you that they're parent of that particular individual. They want to know how their child is doing. You will not just wait till the child comes back to real senses and wait for them to tell you that, okay, you can tell this information to my mom. You will obviously release some information in the form of what their health status is. You cannot give all the details, but you can give the minimal required information. And it makes sense. If you just imagine this such scenarios in your head, everything will make sense. Like, yes, it's making sense. Obviously, you cannot deny the information to somebody who is claiming to be a relative just because no release of information has been signed by the patient. So minimal required information concept comes there. And similarly, limited information can be released to insurance companies. Some information, for example, the insurance wants to know how much time the patient needs to be hospitalized, what are the care options, what is the condition. You can just tell them the minimally required information. Never assume what the patient wants to know. That's the first thing. You cannot assume that they want to know their diagnosis. You just ask them always. That's why I told you previously as well, open-ended questions are the way to go. Never assume that they want to share information with someone, whether it be somebody very, very close to them. So that whenever they are with someone, ask them whether you would like to they would like someone to be with them, whether they would like to hear some details about their medical condition, especially in a bad news disclosure. And we'll see what the spikes protocol is. Spikes protocol for bad news is that you will set the stage, which means that you will make a where you will set the stage in a scenario that is having some respect for the confidentiality. It's a private room mostly for counseling. And then you have got the next step of perception. Always try to see what the patient's perception of the condition is. Always ask what they know, what they want to know is the next step, which is called invitation. You invite them to their medical diagnosis. You try to know, invite them whether they want to know it now, whether they want to hear the results or anything like that. Finally, knowledge, how much did you already know about it, and empathy. And finally, summary and strategy. So this is the spikes protocol, something we'll see for bad news and serious news. Uh, Communicate clinical uncertainty without alarms and without holding information. There has to be a right balance when it comes to clinical uncertainty. What is that meaning really? Clinical uncertainty means that you have got, for example, you saw a test that has got quite a few number of possible false positives and it's a serious condition and you want to reject. So you always communicate in a manner that patient does not get those alarms sounding that this is a very serious condition, and they're not just held from the information themselves. So you tell them that we have got a test that had some concerning results, but we can never be too sure about it. We need to repeat this test, or we need to do a further test before giving you any pertinent diagnosis. But for now, that what we need to know is that this is a concern that we have from whatever results we have so far. So this is why communication of clinical uncertainty is important. Therapeutic privilege, it means the ethical holding of confidentiality that can be employed to save patient profits. For example, the patient has the right to know information for themselves. But if the patient is getting harmed from that, obviously we want to protect the patient from any kind of harm. You can withhold information there. Now, this is something that has very, very gray boundaries, right? So you will never see this as the right answer in your exam. You'll never see it as an option, maybe even. But this concept will come around in your question stems in this particular manner, mostly that you have a patient's family member coming to you and requesting you that they do not want the patient to know of their medical condition if it's a serious news. What you need to do in that scenario is just to explore the concept of therapeutic privilege, just to explore whether therapeutic privilege can be applied or not. It's not that you're marking it as the right answer, just to explore it. You always ask that particular member of why are they saying that? What is the reason of them saying that? You cannot just deny them. No, the patient needs to know that. You have to request and you have to ask what is the reasoning. If, for example, the reasoning is very, very valid, if they think that the patient has got multiple suicidal attempts previously, or he would just go into another suicide attempt because of this information, then the next step comes. But the next step is something that they do not test you. They do not test you on therapeutic privilege. So always the first step, that is something you need to remember. Again, surrounding confidentiality, there's another exception. You have some diseases that are reportable. You cannot respect patient confidentiality in those scenarios. So reportable diseases must be reported to the CDC while informing the patient. So you cannot just disclose hide it from the patient that you're telling them. You have to tell the patient that this information needs to be reported. This disease needs to be reported. And the most commonly reportable diseases that you will see on USMLE are STDs. You can have a whole list online. You can search about it, that which one of them are reported, but it does not include warts. That is the key. Most of the sexually transmitted diseases, you will see that they include, or they are mostly reportable. Contagious infectious diseases, for example, tuberculosis, for example, measles, varicella. If something is contagious and the patient needs to be separated, especially, then that needs to be reported as well. Why? Because obviously, in such scenarios, the contacts need to be aware too. Now, should the physician tell the patient contact? For example, if someone has a sexual partner and they have an STD, the physician should never tell the partner of their diagnosis. The physician has no right or authority to do that. What the physician does is that the physician will report to the local health authority, for example, the CDC, and they have the responsibility to disclosing it to their partners. So that is one thing. Another scenario that they'd like to explore around this particular theme is that they like you to tell the patient, or they like you to request the patient that they should at least report it to their partners, or tell it to their partners, so that they can get tested and they can get treated if they have the disease. So that theme can be explored too around these scenarios. Next thing, we have child and elder abuse. Child and elder abuse needs to be always reported to protective services. And what does abuse means? Means suspicion of abuse as well. So it does not have to be a clear-cut established abuse case. Even when you have the slightest suspicion, you need to report it to protective services. And obviously you will have those markers of abuse that you will read about, for example, injuries of different uh, healing times, broken bones in children that are not supposed to be broken, all kinds of those abuse related targeted findings. Whenever you see them, you spot them, you see a patient that is hesitant, a child or an elder that is hesitant in front of the patient, the people accompanying them, you think of abuse and you report to protective services. That's the first step. You report to protective services. They will handle the investigation bit. They will handle whether it's an abuse scenario or not. You just do it on your suspicion. Next thing that you try to do is you try to interview the patient alone. So you have to be ethical, you have to be polite. You cannot just put it on the patient. They will also give you this option. that you are putting it on the patient, that you are asking the patient whether if they want their mom or their dad, if it's a child, that whether they want them to stay or not. You cannot put it on the patient. You know that it's a tricky scenario. You know that's a difficult scenario for a patient. You're suspecting that at least, and you will tell the parents themselves while being polite that can you please step out? I need to interview the patient. So there is that tricky dilemma as well. Next thing, now contrast. We have child abuse, elder abuse that needs to be reported. We have spouse abuse that does not need to be reported, which is weird, but that is how ethics follows. So you cannot report abuse without patient consent. So anytime the patient has got abuse in the form domestic abuse, you offer support. And the most commonly tested concept is that you offer whether they have a safety plan or not. They have a safety plan in case things go really bad for them. If they do not have a safety plan, try to form a safety plan with them. Try to ask them where they could go in case, whether they have a family, whether they have a supportive friend, any kind of that. You can have information that you can provide in the form of supportive groups and etc. like that, and tell them that they can always contact them for any aid. So you have to offer the support as well. This is how you handle scenarios of spousal abuse. Finally, obviously, violent and criminal activities. For example, those that are surrounding firearms or stabs, you report them to the police. Another case of reporting that we need to do is for impaired drivers to a licensing authority. This is something that I have not seen tested on ethics question stems, but what is more commonly tested is that they want you to know that the physician should at least be this empathetic person to the patient and to suggest them the modes of transportation, alternate modes of transportation in case they're impaired. And obviously, they will have to report it to the licensing authority. So this is some exceptions to confidentiality and how you can have to disclose that information outside the patient. Next thing, the Family Medical Leave Act. This is something again I've not seen tested, but something that you should be aware of. It's an unpaid but job protected leave of up to 12 weeks, which means that the patient will not lose their job, but it's an unpaid leave. And all it requires that the physician signs to release some medical information in an employer form. So the employer wants to know why is this patient applicable to this act. The physician gives them the relevant medical information. So they're disclosing that medical information. And this is the Family Medical Leave Act. The other two are disabilities and how the physician can do that or document that or release the information surrounding that. We have short-term disability, which lasts less than 6 weeks. It's on physician judgment, on physician's diagnosis, whether the patient will be disabled for less than 6 weeks, they need bed rest or anything like that. And this would be a paid leave. So mostly the short-term disability is covered through a private insurance company, and physician requires to certify that information. So physician certification is required. Long-term disability is, however, different. It is more than 6 weeks. It is funded mostly through a federal program, but sometimes obviously private can be involved as well. And again, physician certification is required. So disability plans, as I've told you, they are paid leaves. They're not unpaid. And they also require pertinent medical information to be released to the funding agency. So again, it's a form of minimal disclosure that we have read about. Language interpreters. This is a tested scenario in ethics. First of all, you need to know what health literacy is. There is a concept of low health literacy, and it is often confused with health knowledge or medical knowledge. Medical knowledge is separate from health literacy. Health literacy just means that the patient has got that awareness of what their healthcare plan is or what their condition is. Just that awareness or the literacy around that is called health literacy. So the most common reason why we have low health literacy in population or something that they would test you about are the communication barriers. You can have a communication barrier with the patient. The patient might not know their full information, and that will present as a low health literacy. So they might not be able to take the best decision. So address that communication barriers. For communication barriers, language interpreters need to be professional. Always the right answer is a professional interpreter. Now, a professional interpreter could be telephonic, could be in person, and normally those services are present in in good hospital setups in the states. So professional interpreters need to be the right answer in a non-emergency scenario. Even in an emergency scenario, professional interpreters are the right answer. So when you have to choose a language interpreter and they give you that the patient's family can communicate to the patient, anybody else is offering to communicate in behalf just because they know the language, your answer should be professional interpreter. And in an emergency,
A non-professional interpreter, which means somebody who's close or somebody who has medical knowledge, they can be used if the profession is not available. So only if the profession is not available, then that is the right answer. That too in an emergency. In a non-emergency, you have to wait for the professional interpreter. Simple as that. Now, something that the test is how you will use that language interpreter. So the interpreter should stand beside or behind the patient for a spoken language. So if you are speaking to the patient, that interpreter can just stand there beside the patient or behind them, and the physician will talk to the patient directly. The physician will always talk to the patient directly, and behind them, the interpreter will just interpret what the patient is saying or the physician is saying, right? For sign language, it differs. For sign language, the interpreter comes right behind, beside the physician, because he has to communicate the signs to the patient of what the physician is telling, and the physician will again look at the patient and talk to them like normal patients. So the physician does not need to make the patient feel that they're talking to somebody else and not themselves. So this is something that you should know.